for taking us through the concepts and principles of management of congenital vertical talus. Madam does not need any introduction. She is pioneer of pediatric orthopedics in India, and she was past president of Pediatric Orthopedic Society of India. She's chief of CMC Vellore. She has recently retired of her clinical responsibilities, but she is attached with AMARA Hospital at Tirupati. And she has phenomenal basic research and huge work experience. And I'm sure that her time will help all of us in learning the principles of congenital vertical talus. So thank you, ma'am, for accepting the invitation, and kindly share your screen, please. Yes, we
Good
can
morning,
see this.
everybody.
Yeah, thank you, ma'am.
Can you see the screen? I'll just make this small, right? Good morning, everybody.
Good morning.
Congenital vertical talus is a very uncommon problem. So I think there is a lack of familiarity on the part of even the experienced pediatric orthopedic surgeons with the management. And to understand, especially regarding diagnosis, how to differentiate it from other similar pathologies, and when to use which treatment. So I hope that what I would be talking about today will help in uh, this. So congenital vertical talus, as you know, is also called rocker bottom foot, congenital convex pes valgus, in addition to the thing. So there is basically the important and major defect here is that there is a dorsolateral subluxation of navicular with the dorsiflexion of the forefoot, dorsiflexion and valgus of the forefoot. The hindfoot may stay in equinus, and this in congenital vertical talus deformity is rigid. As you can see here, it's also known as a Persian slipper because, and the rocker bottom deformity. Rocker bottom because the heel goes up, the forefoot goes up, and the talus actually presses down, giving a rocker-like appearance. And Persian slipper because of the shape of the foot, where both the posterior and the anterior parts are dorsiflex because of the calcaneus deformity and the forefoot dorsiflexion deformity. So usually, as we said, it is far, more than 40, 50 times less common than the clubfoot deformity. They are usually bilateral and they are often syndromic, and they have a very strong association with other neuromuscular disorders like sacral agenesis, diastematomyelia, myelodysplasia, and arthrogryposis. It is also associated with genetic disorder. Why we mention this in the management is it's important to understand that these other problems exist, to investigate for them and to treat them at the same time. Because if we do not investigate and we do not know about them, it's quite likely that we'll miss some of these, especially in the chromosome 18 abnormalities with the deletion in the Q region tends to cause foot deformities, of which the vertical talus is one. Other mutations in trisomy 13, 15, Hook's gene, CDMP1, multiple pterygium syndrome as a component of Rubinstein-Taybi syndrome, and chondrodysplasia punctata. So all of these are things we should be aware of, because if you're not aware of it, you're sure to miss some of these conditions. In the vertical talus itself, if you look at it, usually we always talk about the talonavicular dislocation, but the more severe type of the congenital vertical talus, not just the talonavicular, but the calcaneocuboid is also dislocated. These are called Coleman type 1 and Coleman type 2. Obviously, with the talonavicular and calcaneocuboid both being dislocated, the second version is more resistant to treatment and also more syndromic and more severe. Clinical examination, I think since we have some presentation with the fellows, we'll go through it again. But basically what we have to understand is that the hind foot is in equinus and forefoot is in valgus and in dorsiflexion. Okay. So and therefore on the medial border of the foot it will be convex. The sole will be convex, and because the medial border of the foot is convex, there is a bony feel to it, and that is usually the head of the talus pointing straight down. This convexity of the foot does not correct on weight bearing. In flexible flat foot, when you weight bear, the whole foot becomes parallel to the ground, but not so in the vertical talus, where it maintains its convex appearance. In addition to that, there is a deep skin crease at the ankle region and in anterolateral area, where usually in the club foot you see the talar prominence. Here you see a depression or a dimple on this position, where you otherwise in club foot you would be seeing a prominence. The foot is definitely very rigid, and ankle plantar flexion is restricted. You can't plantar flex the ankle. In these situations, as we mentioned, you have to do a neurological examination and you have to do a systemic examination. Older children will have callosities, they will have abnormal shoe wear, and they have no heel push off when they walk. And in still older children, by the time they reach adolescence, they also have painful feet because they start to get osteoarthritic changes. So what are the differential diagnoses? The one people mostly talk about is the oblique talus, pes planovalgus, and posteromedial bowing of tibia. So we will, in the radiographic, I talked about in clinically how you see that there can be differences. We'll talk about more differences in between these three when we come to the radiology part of it. So coming to the radiology, I'll talk a little bit about the normal radiology and abnormal radiology before we will talk about, even though a lot of angles and x-rays and changes are described in the vertical talus, for treatment purposes, we need to remember only 2 or 3, which help us to make a diagnosis and which help us to determine whether the correction has occurred. But it's good to know all the others so that you know what is going on. So in the lateral view, when you look at a very young infant X-ray, you will see the 2 bones of the talus and calcaneum. And you can see the talus is pointing vertically downward, okay? And when you look at the sole, you can see the sole has a very convex outline. You don't see the heel prominence, but you see instead a convex outline of the sole of the foot. And this is also what looks like a rock bottom contour of the foot, okay? As the child gets older, the navicular does not ossify till 3 to 5 years. So in a child younger than that, in the place where the navicular will be, there'll be a gap. And what you will see in a slightly older child where the first cuneiform has appeared, here you can see the first cuneiform has appeared. There's a gap between the first cuneiform and the talus. That is not that what you see as the smaller outline is not the navicular. Navicular, it takes longer to ossify. It's the gap where the smaller bone is seen opposite that. That's where the navicular will be in line with that. So this is sorry. Investment. I'm sorry. So the navicular is ossifies only by 3 to 5 years. So it's represented by a gap prior to that. So the bone ossified over the talus, here is the medial cuneiform, and that indicates the position of the navicular, okay? Little older child, this is 6-year-old. Now you can see that the navicular is there, and this particular navicular looks like this has got a slight avian kind of thing. It's got an epiphysitis, but that's where it is. And you can see it is not articulating anywhere near the head of the talus, but there is usually an articular cartilage on this dorsal of the talus, which is with which this navicular is articulated. So it articulates with the dorsals of the talus. So it is absolutely dislocated. Okay. Then the angle, talocalcaneal angle, usually it should be between 25 to 50. It will be increased in the congenital vertical talus. In the talus, first metatarsal angle, normally it is, you can see a line passing through the first metatarsal and a line passing through the mid-axis of the talus. Normally it will be either 0 to minus 20, that is pointing downwards. As the foot becomes flat, it will become more and more positive. And when it is in dorsiflex position, that usually will be a vertical talus or even oblique talus. Okay. Now coming to the tibiocalcaneal angle, the tibiocalcaneal angle normally is 10 to 40 degree. Okay. It demonstrates if it starts to get beyond that, that is, it starts to go down to the opposite side, that is minus side, then that means that your calcaneum is in equinus, and that is what happens in congenital vertical talus. Now, looking at the tibiotalar angle, that is commonly used in the congenital vertical talus, not the other ones, but the tibiotalar, because it's usually the angle between the tibia and talus is almost vertical, or, it's like normal is 110 degree and less. And here it is beyond 110 degree. More likely in a vertical talus, it will be beyond 145 degree. The other one is talo horizontal angle. This again is about 35 degrees to 25 degree in the children. And this again becomes very, very vertical and almost reaching 90 degree in the congenital vertical talus. This is something, these things are very important when you're doing operating. These are in the lines which you draw to the center of the calcaneum and center of the talus. So you see in the normal, the line passing to the center of the talus pass to the inferior part of the cuboid. There's a nice big bone when you see in the x-rays in the theater, and you can very easily recognize it. And the line passing to the center of the calcaneum passes to the upper part of the cuboid. So when you see this, you recognize that this is what the normal alignment should be. However, in the vertical talus, both the lines will pass below the cuboid. And in fact, the talar line will almost pass through the anterior end of the calcaneum. So remember these two lines when you're looking at x-rays in the theater. And I'll come to it later when we talk seeing the post-op x-rays. AP view, the angles are between 25 to 40 degree between the talus and calcaneum in the AP view, and any angle more than 35 degree is considered as abnormal. Okay, and that is what we would see in the vertical talus. Okay, so this is what you see, more than 35 degree in the in these. So look, radiographs usually you take weight bearing X-rays and you take forced plantar flexion view. So in the weight bearing X-rays, talar angle close to 90 degree, tibiotalar angle close to 90 degree, and in the AP view you see an angle greater than 35 degree. Here, of course, about 60 degree. Then coming to the plantar flexion view, when you attempt plantar flexion itself in the photograph itself, you can see that the heel is not plantar flexing at all. It is just staying where it is. And you can also start seeing the subluxated position of the forefoot. Okay, you can see that it's prominent there and it's subluxated. And on the medial side of the heel, you can see the prominence of the talus. So all these are seen even in the patient. So in the dorsiflex view, you prove that in the maxillary dorsiflex, you can show that there is a rigid fixed equinus, which is a feature of most of the vertical talus. Now, the most important measurement is in the forced plantar flex view. You can see that the talus, the line passing through the talus and a line passing through the first metatarsal. You can see that there is not just there is a dorsiflexion compared to the talus. So that not just that the talo-first metatarsal angle is grossly dorsiflexed, it also does not meet, which means that the joint, it is dislocated. It's not in line with the joint is dislocated. So this is not in line with the normal talo-metatarsal joint. So this is a great way to distinguish when the joint is dislocated and is not in contact. That is what you usually see in the flat foot. When the joint is dislocated but reduces, the talonavicular joint reduces mostly on the plantar flexion, then it is a oblique talus. So I think that's the way most people will differentiate. I think you will have a little talk later on by Dr. Dhiren Kanjwala on the recent paper where they have said about how to distinguish between oblique talus, flat foot, and vertical talus based on these measurements. But mainly, the importance is of the plantar flexion view in this condition, lateral plantar flexion. So in the oblique talus here, you can see that it is not, it is reducing in the plantar flexion view. So that is the difference. In the flat foot, the articulation is never lost. So even in the view in which you are weight bearing, you can see that the anterior end of the talus articulates with the navicular. So this is not lost. In addition, in the various views as well as on the other scans, etc., you can see the pathology of a rigid flat foot where there may be tarsal coalition and other pathologies. So how do we manage? So management, I think, is good to know that an algorithm to follow, because it's not like nowadays, just like in clubfoot, in vertical talus as well, we don't straight away jump into surgery. Even when the deformity is very severe and you know that the surgery is required, a few castings help, because otherwise the anterior skin and anterolateral skin could be very, very tight and you could get it's skin problems and the wound dehiscence problem. So now, as a rule, in general, everybody uses a few casts, even in the congenital vertical talus, even in a late vertical talus deformity. However, in the younger children and the non-syndromic vertical talus, management always starts with the reverse paucity serial casting. That has been described by Dobbs in 2006. And since then, from Dobbs' work itself, there have been at least 4 papers at different stages, in different numbers and different duration of follow, which have talked about the outcome of Dobbs. And whatever, whether we agree with him or don't agree with him, we have to admit that the results are quite good when compared to the more open, extensive treatment methods for the congenital vertical talus. Minimal surgical approach may be quite sufficient when you're seeing the patient in the infancy, and more severe stiff and recurrent feet may require more extensive releases. Sometimes when you start off with doing these minimal surgical approaches, so many releases are required that you start to wonder whether you're doing a piecemeal, more extensive exposure. So I'll just talk about an algorithm for treatment. This algorithm is by, okay, the name is not coming to by Mary's Butchard, and it is given in the Postna 2022. I think if you have access to it, that's good, because that's a very nice article on how to treat the early stages of the congenital vertical talus. So she suggests that you always start with serial casting and see if you can reduce the talonavicular joint. Here, I think it's good to just actually at the end of the reduction, even check if you are able to get those in the lateral view, the midline of the talus and midline of the calcaneum, and see you're able to get it through the cuboid. If you can do that, I think you can proceed then to doing a talonavicular joint reduction with K-wiring. So if talonavicular joint is reducible, then you continue with casting, and then you continue with the molded footwear, and you go ahead because you don't need a surgical intervention. But if it is not reducible, or it is only partially reducible, then you have to do a minimally invasive talonavicular joint reduction and Achilles stenotomy. So here you first start off with doing a medial subtalar joint release. And then if you can't plantar flex in addition to that, then you have to lengthen the toe extensors. And you will find after that you cannot adduct also, and adduction is less than 10 degree. Then you also have to lengthen peroneus brevis and release the lateral subtalar joint. If you find that the talonavicular joint is not reducible and deformity is severe, stiff, or recurrent, and if there is significant lack of plantar flexion. So there are several approaches here. She has talked about the transverse dorsal approach for dorsolateral releases, but there are many other approaches. She also uses Cincinnati. Other people also use 2 incision approaches. They use a single incision approach, and they use a Cincinnati approach. And there's an older approach, which was the 2-staged approach. They first did the anterior releases and they reduced it. And at a second stage, they went back and did the lengthening of the tender Achilles. So if there is a significant equinus, you will need to do, in addition to the releases, you need to do the posterior release of ankle and subtalar joint. If the medial column is too long, then you may have to do a bony procedure, maybe excise the navicular to get rid of the longer medial column. So we'll start off with the Dobbs reverse paucity technique. So just like you have a system, like you'd say cave in the, when you do the paucity procedure, here you start off with the lateral side, you stretch the lateral structure first, and then gently press at high pressure to reduce the talonavicular calcaneocuboid and calcaneocuboid joint. So for first lateral structure are stretched, then you adduct the adduction of hindfoot on midfoot, or adduction of midfoot on hindfoot, whichever way you look at it. After you invert the subtalar joint, and then you attempt so once the medial part of the subtalar joint is in contact, then you do the plantar flexion and stretch the anterior structures. Then you mold the cast at the medial arch to maintain the talonavicular reduction. 5 to 7 casts are required. If your child is less than 2 years, then you will need to do an above knee cast. If the child is more than 2 years, then you can get away with below knee cast. 5 to 7 casts are required. Some of the things that you must remember is that when you extend the cast above the knee, maintain the knee inflection, 90-degree and neutral rotation. You should have very snug padding in midfoot because very loose padding in this area will not allow you to mold. Molding over the arch and midfoot is essential. You have to extend the cast nicely over the toes. Otherwise, the MP joint will extend and you will not be able to stretch the toe extensors. And once you have finished casting and either you've got correction or when you're waiting for surgery, you need to shift to a molded AFO. Even when you're waiting for surgery, you shift to the AFO and then again recast again 2-3 times just before planning for your minimally invasive surgery. So some of the other things that you can do is to use twice a week cast rather than twice a week rather than once a week. Twice a week rather than once a week because you can finish faster and you can do it quickly. Above knee casts are preferred. In older children, you can use below knee. If not reduced, then minimally invasive navicular reduction plus minus T18 and hold with K wires. That is as Dob has described. So several series, I'm just mentioning 3. One is the first in 2006, 19 feet and 11 children with I think about 28 weeks or 28 months or something follow-up. Then 13 patients with 21 feet with 33% recurrence, with more recurrence occurring in syndromic feet as well as those who did not have the talonavicular reduction. Then recently, Dobbs' paper himself, I think Yang and Dobbs or something, where they have described long-term results of greater than 5 years and showed that they had better results in the more extensive release procedures. So just to give you an example, this is an infant with foot deformity, which is not syndromic. I'm sure you can see that the talus is pointing vertically down, and you can see that the talus and calcaneum definitely are not looking, I mean, AP view is not really AP, it's oblique, so I think it will be better not to comment on it. But looking at the plantar flexion view, which is being attempted, you can see that it is a vertical talus, okay? So after 6 weeks of casting, if you started to draw the angle, you can see that here is the good way to check. See, if you do the lines through your talus, you can see that you will go below the cuboid and almost to the anterior end of talus. So we have not reduced. So after this, we had gone in for close reduction pinning. So what we had done here is to get the dorsiflexion of the calcaneum, we've used a K wire. And when you drew that, we were able to actually do a close reduction without actually opening the talonavicular joint. Okay. We did need to do the TA lengthening though. T18 had to be done. So open reduction of talonavicular joint was not required in this. And here you can see we have used actually kept the wire also. And this is the other side. We kept the wire also in that calcaneum, which is used in the calcaneum because it maintains we have advanced it into the cuboid because that helps to maintain the reduction as well. So post-operative treatment, it is a little different from what is recommended, and I'll tell you what is recommended because of the way we work in India with patients coming from thousands of kilometers away, so they can't come every 3 weeks. So you usually do a above knee molded cast between 6 to 12 weeks, depending upon the age of the child, usually around 10 weeks. Wire removal at that time and change to molded orthosis. And for the older children, if you are calling them at about 2 months, then you may need a second cast for another 6 weeks with more dorsiflexion of the foot. And then you give a molded orthosis for at least 6 months. And in addition to that, you have a footwear with the arch support and medial wedge after that. And boots for those who are under 2 years and are not going to be so well held by the AFO all the time. They also, in addition, have boots and bar, where the boots are in neutral position for 14 hours a day. In syndromic feet, AFO will continue throughout the growth period. So in syndromic feet, AFO never come off. It's just like clubfoot. To correct a syndromic feet clubfoot, you do need to use the AFO for a very long time till they finish growing. The post-operative protocols as recommended this is the AOS guidelines. And they say first they put a 3-week cast. After 3 weeks, they dorsiflex to about 5 to 15 degree and change the cast. And then again at 3 weeks, they change the cast. At that time, they take the A4 at that time, and they change to short leg if the patient is above 2 years. And then at 8 weeks, they go back into the theater, they remove the wires, and then they provide the A4 after that. And after that, they follow up for that. So these A4s are initially a free range, well molded arch for daytime if they're walking. Under 2 years, they use boots and bar. And initially, throughout the day, and later on they slowly wean it off till they are only wearing it for about 12 hours a day. And brace wear is for total of 2 years if it's an isolated deformity, and remaining time they use the brace. Okay. For older children and relapse cases, if they're over 2 years old, you do initially casting followed by soft tissue releases, talonavicular reduction and KY fixation. Calcaneocuboid reduction may sometimes be required because the deformity could be very rigid, and KY fixation, and split tibialis anterior transfer, and transfer of 1/3 of the split tiband to the neck of talus. This is what we do. So this is just to show you there are two incisions. We have two approaches. We use both. We use an anterior approach as well as we use two incision approach. The two incisions are medial and lateral with an additional incision in the leg if it is required. Lateral incision can be actually extended further back to do the TA, or sometimes you can do with the medial. I usually extend the lateral and do the TA with that. With the anterior incision, you go from just below one medial malleolus to the lateral malleolus. You require a separate small incision to do the tenotomy, or a slightly bigger one if you need to do something more than that. There is no difference in the results. We have done 15 in each group, which we followed up. There's no difference in the results between the double incision and anterior approach. However, the anterior incision makes the procedure very much easier. You don't realize there are a lot of adhesions and fibrous tissue between the neck of the talus and the anterior part of the tibia, and these are best released by the anterior approach. So the procedure is much easier, but also the skin adhesion chances are much higher with the anterior approach. So coming to the the double incision technique, this is single stage double incision, and we do the tiband split transfer if the patient is over 2 years old. But it's not entirely necessary, but we find it works better if we do the tiband split transfer, because remember, talus is a bone with no attachment of any tendon at all. So if you want to keep it up and stop it from falling, it might be a good idea to help it with something which holds it up. So that on that basis, I always in the older children tend to do this. Two-stage technique that is described is hardly done anywhere. Everybody does it at the same time. Just an example, this child, you can see the convexity of the plantar aspect here. You can see that you cannot plantar flex even to 25 degree. Plantar flexion is very tight. So before we started, we have lengthened the EDL here. Then on the lateral side, we have done the peroneus brevis lengthening and TA lengthening here. And then from the medial side, we have released the talonavicular joint. And this first wire actually is holding a calcaneocuboid, which we reduced from the lateral side. And the second wire holds the second wire past retrograde and then into the first metatarsus holds the medial side. Okay, this is the after correction. You can see that the convexity has already disappeared, and actually the incisions are very much in the creases, so they don't really form bad scars here. So this is result, and this is how it looks. These are the results. So you can see this. This is pre. You can see this is again, you can see almost vertical talus. And this is post. You can see how the talo first metatarsal angles are very much within the normal limit. And the lateral view also, you can see that the line to the talus actually will pass exactly through the middle of the cuboid, and so would the calcaneum. So this is well reduced. Another one, patient, this is at 3 years of age, this child. You can see vertical talus appearance there, and then you can see the post-op correction on the right-hand side for the right side. And then here on the left side, again, you can see the angles. It's almost 60-degree plantar flexed here in the dorsiflex view. And then you can see post-op correction. Again, this is an older child with many years follow-up. So what do you do when you have in children older than 3 years? They may require shortening of the lateral column. a shortening of the medial column because the lateral column is shorter and it needs to be accommodated. So you may need to do excision of the navicular. Other procedures suggested are subtalar arthrodesis, triple arthrodesis. We have never had to do talectomy. If you excise the navicular, you can very often manage the talus reduction. You don't have to remove the talus. This is a very much older child. I don't remember the age exactly, but with the severe deformity. This is extremely severe deformity. You can see very obvious dislocation of both the talus and the cuboid here. This is the AP view. And you can see this the X-ray we were talking about, how it doesn't reduce when you flex it. So here we have to release not just the, we had to release not just the lengthen, not just the digitorum, but also the tiband here. And it's a laterally, we have done the peroneus brevis, reduction of the talo-navicular joint here, and then tibialis anterior 1/3 transfer to the neck, and a calcaneocuboid also reduced and held with K-virus. So this is how it looks. Again, I think you get in the habit of looking at the orientation, the calcaneus and talus with the cuboid, because cuboid is a big bone and you can very easily spot the midpoint of it. Other bones are small in a child and very, very difficult to look at. So this is the pre-op X-ray of the child. You can see actually the whole of the navicular is articulating with almost all of the extra articular part of the anterior surface of the talus. And here you can see it has been reduced. The navicular is misshapen. You can't change that. That is how it was to start with. The tiband, split transfer of tiband. Some people talk about transferring the whole tiband. But that is actually, it's a very strong muscle, and talus is not its normal point of action. So that might not be something which is a very good idea. So we transfer the 1/3 of the tiband. Some people recommend that you transfer 1/2 of the tiband, but transferring the whole thing might be a little bit of an overdo. This helps to maintain the neck of talus in dorsiflex position. And these patients you then immobilize in the Vellore cast in these older children with heel in dorsiflexion, forefoot in plantar flexion, and in reduction. And older children, one of the complications, especially when you had to do a lot of struggle in while you're trying to reduce, you might land up with avascular necrosis of the navicular because almost completely loses its blood supply. So now I'm just going to talk about the complications. And there are many complications that can happen. And the commonest complication is recurrence. You can't always be sure, especially in syndromic children. Even in the literature, more than 30% of patients having recurrence have been described. And this is very, very common. So either partial or complete recurrence is a very common deformity. Skin necrosis, again, is very common, especially when you're using one of these anterior wounds, because that becomes very tight when you straighten it. Avascular necrosis of navicular is a common complication. Calcaneus deformity, when you do a lot of lengthening of the tendoachilles and your tiband is transferred and becomes very, very tight, then again you can have a problem. Osteoarthritis of the foot joint can occur at a later stage. It can also occur if the patient is untreated. Then some of the sensory nerves like superficial peroneal nerve branches and posterior tibial nerve branches are also at risk. Then stiffness and osteoarthritis, of course, the common complication. I think that's all that I have to say. So we can now move on to other parts of the program that we have, case presentation and these.
So thank you, ma'am. So that was a nice talk, and we have few questions. Dr. Dhirenbhai is not going to talk because he had some other commitment. So we have discussion on vertical talus only. We have a few questions, and
I think Dhiren's paper, I think everybody would have read, I think. He emphasizes that all the Tamba and Kamba and all that stuff, which are very difficult to remember, are
Yeah.
not really relevant. But what is more relevant is the articulation in the forced plantar flexion view of the between the talo-navicular joint. I think that is the main crux of his paper. That too, there are two things you're looking at. You're looking at the deformity and how much the deformity corrects. and secondly, whether there's a dislocation, significant dislocation there or not. So if you have a dislocation, you're considering vertical talus
Exactly.
and oblique talus. If the dislocation reduces, then you're considering oblique talus. And if there is a dorsiflexion but no change of cora, that is, there's no dislocation, then you're considering flexible flat foot or flat foot, rigid flat foot. I think that is what I understood from him. I just looked up today his paper to see what he was saying. I think that's what he's saying.
Yeah. So we will soon have a interesting papers from Pawsey session, and I'll invite him there, and he can talk about in details. Now, a few questions. The first one I'll take from Dr. Bhushan. How do you define the end point of casting? And he's right that some chubby children, when to switch, go for mini open reduction. Like in Matt Dobbs series, he says that you clinically judge that once it is partly aligned, you go for this. How and it is difficult at times. How do you decide?
Yeah, I think just like I just go by like just how in Ponseti technique, you reach a point when you see no improvement in two casts. So I think you have to see the same thing here. You see no improvement. So I think what is being suggested is that you do no more than 7 casts when you start to do the this correction, and you have done about 5 to 7 casts, and then after that, if you find that your talionavicular joint is still not reducing, then you go ahead and plan to do
Mini.
MUA and a mini open or just a close reduction, because then you can do the close reduction much better in the theater because you have control over the bones. Like you saw that how we did. You saw in the pre-op X-ray, both my sides had not been reduced. So
Yeah.
I was going to do a mini reduction, close mini reduction. But when I went there, when I dorsiflexed the calcaneum using a wire, I was able to reduce using those 2 wires to triangulate. And with those 2 wires, we were able to reduce. So it's possible to do it. But I think the end point should be that you can't put 60, 70 plastic casts. After 5 to 7 plastic casts, you should go into theater and see what you can do.
The question, what I think he indicated is, when is the time to perform talonavicular K wiring? How do you suggest judge it clinically? Maybe after 4 casts, when you think it is ready
I
for
usually
wiring?
take an X. Okay, I usually take an X-ray and see how much the correction is. But clinically, what I'm looking for is that I'm able to adduct about 10 degree or something. I'm able to plantar flex about 15, 20 degree. And I'm able to, what do you call it? Uh, I'm able to plantar flex and adduct the foot, which makes me realize that my soft tissue component has been sorted out. I think clinically that is the end point. Radiology, then you just check and see if your talus is reduced or not. If it is not, then you go into theater for doing the mini open reduction. If it's reduced, then you won't go to theater. You will just go ahead with finish 1 or 2 final casts, 3 weeks each and all that stuff, and then go on to brace.
Now, there was a paper from Jim Wright. I was in Sick Kids when these things came up, Matt Dobbs paper. And then we tried, Maurice Butcher was my resident when I was a fellow. So when we did few close reductions, and when we followed them up at about 1 year, 1.5 years, still the talus was vertical. So the practice changed from close reduction to a mini open because we don't see navicular.
I think that is what I also mentioned in when I was talking, that Wright said that those who did not undergo open reduction were more likely to have relapse. He said 33% relapse in the patients who were treated with the this one's technique, Dobbs technique, 33% chance of relapse when they did not. That was one of the risk factors that no open reduction was done.
Another practical problem is now a lot of newborn with idiopathic vertical talus come to us. In about 3 reverse Ponseti cast, they are almost ready for close reduction or mini open reduction. And that time, family thinks that a 3 months old baby needs to undergo general anesthesia is a problem. So, and in few parents are they don't want to put their child in. How would you manage that situation
I
now?
think I'm managing them with therefore. I've also, when the child is very young, I'm not just like how in clubfoot. when you are finishing all of these various manipulations and wiring and everything, and your child is just 6 months old, they're not ready to weight bear. You're just wondering whether you have reached that endpoint very early. And so I would actually change them to a very well-fitting AFO at that stage, and then reassess them again when they're about 8, 9 months, and then plan accordingly. By that time, the parents also will be quite fed up with the AFO. So they want something more definite done. So I think that's a good time. Also, even for clubfoot, a good time for surgery is around 9 months if you're
Yeah.
having to do the surgery, not at 3 months.
Exactly. So that's impractical. Now, all the fellows in training must understand that in clubfoot we are dealing with only equinus contracture, but in vertical talus we are having double-edged sword, that we are also in dorsiflexion contracture because of T-band tightness, and hindfoot contracture because of TA. So, madam, this has been seen in corrected patients of vertical talus. We see we are not able to plantar flex the foot as much as we want. And you rightly say that in dorsal approach, you see some tibio-talar adhesions. Now, when we do a medial and lateral release, we don't probably address those adhesions. Is that the reason why our patients do not have very good plantar flexion?
I think there is a balance. Like when I shifted from two incision to the anterior approach, I really thought that, I never addressed these before. So there are two ways you can look into it. One is in the older children where you find that you're at the end of all your thing, you're still struggling and your navicular is being very heavily pulled by your tiband. Then you realize that even if you transferred it, you're not going to be able to sort this out completely. So I do a small fractional lengthening of tiband in those cases where the tiband is very, very tight. Second thing is to realize the advantage of being able to release those anterior adhesions. And in such situations where the anterior contractures are very, very tight, you do a good amount of anterior stretching first so that you don't get skin problems. Once you have sorted that skin issue out, then go to the anterior approach. If your major pathology is anterior and not going lateral and so much, then just go for the anterior approach.
Right. That's a great.
The only problem with the anterior approach, which I have found, is the difficulty in sometimes in the skin contraction. I mean, so skin adhesion. I mean, skin dehiscence.
So you do multiple plasters and gradually plantar flex the
I
foot.
think now it's understood. I think universally that like we're not going to do some big flaps and all there. When you can actually put a few plaster casts and stretch
Yeah.
the anterior skin.
Now, how would you? What is your strategy in treating relapses? Or if the deformity is recurrent, and you have not done primarily T-band transfer, how would you approach it?
So I think the relapse feet you will treat exactly as a stiff or extensive, a stiff and very extensively affected vertical talus. So you will go through the motions of releasing what is not released. Most of the time, the problem lies in that you do not do an adequate anterolateral release. That's where the problem lies, especially the lateral release, to realize that unless you release it laterally, you cannot. So if your lateral side is tight, so it's just like how in the congenital clubfoot, in the very severe clubfoot, if you did not do so-called as a subtalar release all round, you cannot actually move the subtalar joint to lie in the correct position. Here, same way, if you did not do a lateral release, and if you did not do a posterior release, you may not be able to position the talocalcaneal joint at all. So that is important. Then second thing is to understand that should be willing in case of his older and extensive problems to sacrifice your navicular. And if you go with that approach right in the beginning, then you're not going to struggle so much. Third is in the older children, sometimes they come at 10, 12, 13. I have had 14 and 15-year-olds coming back with the old arthrogrype cortex with contractures and all. Sometimes you should just aim for a functional foot, which is braceable and with no areas which are going to give rise to callosities, and try to achieve that. Talectomy is supposed to be one of the answers, but I find that most of the time I have not had to do talectomy. You can manage without talectomy.
Have you done talonavicular fusion in some patients where
I've done navicular excision. Talonavicular is good if you can reduce it. If you have not reduced it, I don't see how it will work. You have to be able to reduce. Sometimes it might happen because you damage the talonavicular so much when you are trying to put it back that you might as well fuse it and, take credit for it instead of taking the blame for it.
Right. Now, you said you do fractional lengthening of tibialis anterior, so that is supraretinacular or
Yeah,
infra? Yeah.
supraretinal. That is when it is so tight that you know that if you transferred it, you'll land up with a dorsiflexion contracture. And I've got older patients who have got a dorsiflexion contracture. Actually, that particular thing was not done in Vellore, it was done somewhere else, but there was a very strong dorsiflexion contracture. So that you have to release the event above the supraretinacular area. So infraretinacular, you should concentrate on releasing the fibrous tissue adhesions.
Right. Dr. Anil Agrawal has asked, at what region toe extensors are released? Again, I think
What region?
supraretinal.
I do supraretinacular. I don't know how other people do it. I do it supraretinacular. I think maybe you're thinking in the anterior approach.
Yeah, so that's
Are you thinking in the anterior approach?
me. No, I'm triple incision. So
No, no,
I
I'm
do.
asking Dr. Anil. Is he thinking in the anterior approach?
Anil is here
No,
or
ma'am. No, ma'am. I'm not doing the anterior approach right now. I heard it from
No, if
you
you're not doing
first time.
anterior approach, then do supraretinacular.
Ma'am, I also wanted to inquire whether any kind of like we do in CP, I have tried doing the just fractional lengthening. Or do you do frank lengthening?
I do actual lengthening, yeah.
Z lengthening.
No, fractional lengthening. Fractional lengthening, but I always try to repair it. Because these are very tiny tendons, they'll just disappear. So I always try to repair wherever the edges of it lie. Otherwise, they just disappear. It's difficult to find them.
Okay, ma'am.
And
Just
Dr.
one stitch. I just put one stitch, not one big repair or anything.
So Dr. Anil's another question was, what is your regime of T-band transfer? Do you do it only in the relapse or stiff cases or in all the cases?
I'm not doing it for anybody less than 2 years old because I'm afraid I'll cause an AVN of Talus or some problem like this. But above 2 years, I don't do a very big transfer. Just about 1/3 of the tendon I transfer. It's just like a little sling for to hold the talus up and prevent it. And because it comes from the medial side, it also keeps the talus more medial, So it holds the talus in position where it should be.
Now, one thing new for me from this presentation was to use a calcaneocuboid wire and use as a joystick. So that's a good
No,
idea.
don't use it in the cuboid. First, use it in the calcaneum. Use it as a joystick. And then once you have reduced it, then you pass it. I use it actually to push the talus head up. It's very difficult to control otherwise the talus. And once you have it in line, otherwise you're struggling. No, there's very tiny little space. You can't catch it. So this holds it up and you pass your wire and then you use the same wire to pass through the cuboid.
Right. Now, the question from Dr. Meet Jain is, sometimes when we kind of remove the plaster, the wires get backed out. And he is right that
Yeah,
although
very
you have
common.
transfixed, these children are so much moving.
Yeah. So I thought I have a long discussion every week with the one foot and ankle surgeon from US who was a former fellow, but now she's a consultant there. And she does only syndromic feet. Her major work is on syndromic feet. So she was having a lot of problems with the backing out of the wire. And then we went through all the steps. Then we found out that she does not go through the first metatarsal. First metatarsal is a very strong bone. If you take it from there, it holds the wire well. But if you don't go through that, but go through the navicular area or one of those other areas, the wire is not held well. There's no cortical bone holding it. So the wire backs out. So now she has changed it. So recently her last case, she almost does every 2 weeks, she's doing one case. So we should know. I think I have not got so much problem with the wire backing out, but I always go through the cortical bone. I insert through the cortical bone and then go through. If it's not going through that, it'll back out. There's only Talus. Talus doesn't hold it very well.
One suggestion, Meet, is, like when you reduce the talonavicular joint, it becomes a like tent-like situation. So your talar wire, when you pass it now antegrade, it comes out of navicular, as madam said. So you start little proximal in the talar head. So after talonavicular reduction, your wire will progress to the base of metatarsal, as madam said. And sometimes you may pass a retrograde wire once you have achieved a smaller wire which will hold it well. So that's a great suggestion. And so I think all the questions have been answered well. Dr. P.N. Gupta has asked that he has done TA tenotomy and not conventional Z lengthening, but
We do all tenotomy only.
So in young children, we do tenotomy. Is an older one where we think that there's capsular contracture as well. Then we will do open. That's the practice. We practice T-band. I think all the questions are answered, and we are on the. That was a great talk, ma'am.
We're not going to have any case presentation. That's not fair. Fellows should also sweat a little bit.
Yeah, so as you said, the talk will be a bit extensive. I said let's just focus on discussion and.
All right, sure.
But I'm sure that all these cases had these issues which I asked. There are few important tips, at least I got from this, and I'll reiterate that when we start in young children, we do reverse Ponseti technique. Many a times we reach to the end point earlier. Parents may not agree for under anesthesia procedure, and then you give them a splint and exercises. And maybe around 5-6 months, when family is ready, you can go for procedure. You can have either a dorsal or multiple medial, lateral, and posterior approach. And the adhesions between the tibia and talus should be released so that they have enough plantar flexion as well as dorsiflexion. Once you transfix the wire, put your wire through the metacarpal base and to have a good cortical purchase. Read your x-rays carefully. And finally, for stiff cases, resistant cases, you can do T-band transfer, not complete, but you can have partial transfer. It's a very strong muscle. And there are relapses in older children, and they present in their adolescence. There you might need naviculectomy, and your principle should be to fit them in an orthosis and make their feet plantigrade. So with that fantastic talk, ma'am, thank you very much for your time. And
just one more thing, I just want them to remember that in theatre, we are often struggling to see if the X-ray is okay or not. To remember the position of the wire, that, the talar wire should go through the lower half of the cuboid, and then it will be okay. It's then the direction is correct. That part, if they remember, in the calcaneum also should go to the upper half of the cuboid. If those two are there, I think you don't have to worry too much because you can't see navicular.
Yeah.
And I think tip is something, if they remember, that is also going to help them in theatre.
And once you put the wire, you should and you leave the foot and see the arch has formed well, then it's fine. And I also release tibialis posterior initially, and
you have to do that.
And then advance it. Yeah.
I'm sorry, we didn't talk about that. But when you're doing the medial release, many people do not do the tibialis posterior release, but you should release tip post. Actually, it's much easier to get to it if you do a small Z lengthening there itself. And then after that, you repair it very carefully so that you use it to sort of tighten up that area.
Yes. Yeah. So that's what we do. That with advancement of tip post and tighten, you are kind of creating that medial arch that will also help to some extent. So thank you, ma'am. Professor Anand Kishore Pal was there from Calcutta, and he has mentioned excellent lectures and interaction. Although he's doing adult practice, he regularly attends these rounds. And we took his help in understanding shoulder biomechanics.
Oh, that's nice.
He's heading this Dr. Saha's unit, so he carries his legacy.
Very nice to meet you. Yeah. I don't know. I can't. There I can see him. Very nice.
Thank you, madam. Thank you, madam. Excellent lecture.
So with that, we conclude today's. Yes, any question? Okay. So we conclude today's meeting. Thank you, ma'am, for your time. See you soon for some other academic session. Thank you very much.
Okay. Bye.
Bye-bye. Have a good day.